My name is Abiodun Egwuenu, and today we'll be talking about active case finding for sepsis, sampling and handling of blood cultures. By the end of today's presentation, you will have learned more about sepsis, diagnostic stewardship, active case finding, importance of blood cultures, aseptic blood sampling techniques, and handling of blood culture samples. So what is sepsis? Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Vulnerable persons or populations are at higher risks. This includes children, older aged persons, pregnant women. Annually, 30 million people are affected with sepsis, with about 6 million deaths occurring globally. An estimated 2 million cases of sepsis-related deaths occur in Africa each year. 3 in 1 of these deaths are due to neonatal sepsis, thought to be caused by resistant pathogens. Nigeria accounts for the highest number of neonatal deaths in Africa. 50% of these deaths are attributable to sepsis. Laboratory diagnosis is still an issue also in country, and this leads to antimicrobial misuse and increased mortality. Why are hospitals important for antimicrobial resistance, emergence, and control? This is because multi-drug resistant bacteria spread more in the hospitals. In the hospitals, antibiotic use is higher than in the community. And there are other predisposing factors such as immobility, use of devices, and being an enclosed space makes proliferation of these bacteria, especially if they are multi-drug resistant, it makes the proliferation more. Blood cultures have been prioritized globally as indicator specimen for antimicrobial resistance surveillance. And several bacteria have also been prioritized from blood cultures. This is because these bacteria can cause severe and often deadly infections. Diagnostic stewardship refers to appropriate use of microbiological diagnostics and laboratory testing to guide patient management and inform empiric treatment guidelines. Blood cultures can support rational choice of targeted antibiotic treatment and also inform infection prevention and control measures. Is sepsis an issue in Nigeria? Data from 2 hospitals suggests so. Out of 40,000 patients that were seen in a hospital from October 2020 till May 2021, 2,618 were found out to be sepsis patients, giving a prevalence of 6%. And looking at the age distribution of this suspected sepsis patient, majority were 14 years or below, with the highest burden noted between children aged 1 month to 5 years. When clinicians were asked about sepsis definition, diagnosis, and management from these 2 hospitals, clinicians stated that they felt sepsis is an infection of the blood. In addition, 56% agree that a brief history and physical examination with laboratory investigation aids in sepsis diagnosis. And why do they start antibiotics? 78% stated that severity of symptoms at presentation and the focus of infection should guide antibiotic therapy. Looking at the community hospital healthcare continuum, majority of the hospital, called the total population, are residing with or without symptoms. Talking about diagnostic stewardship. Diagnostic stewardship, also called the total testing process, occurs in 3 phases. In the pre-analytic phase, a patient presents from the community and the clinician poses the question. This question refers to taking a clinical history, physical examination, and then coming up with a diagnosis that supports with test selection. After the test has been selected, this test is ordered and the specimen that should be collected is identified. Following specimen collection, this sample is transported into the laboratory. Once the sample gets into the laboratory, the analytic phase starts. This sample is then processed and prepared for analysis. Following analysis, a report is generated, which is provided back to the clinician, now reviewed and interpreted, and the clinician takes action. This cycle goes on and on. However, if care is not taken, errors can occur in any of these phases. It's been found out that in the diagnostic stewardship continuum, 32 to 75% of the errors occur in the pre-analytic phase, 13 to 32% of the errors occur in the analytic phase, while 9 to 31% of the errors occur in the post-analytic phase. In the pre-analytic phase, such errors are detrimental. It leads to unnecessary patient investigation, inappropriate therapy, and could even increase hospital stay. So it's garbage in, garbage out. Preventing pre-analytic errors is important for diagnostic stewardship and quality of patient care. So in the pre-analytic phase, it is important to consider the following outside the lab. You need to consider the indication. You need to order the correct test or sample. You need to prepare the patient and the material, label the specimen correctly, complete the request form, take sufficient sample following aseptic procedures, and use proper packaging and transport. Inside the lab, the data should be entered correctly and checked according to the sample criteria, and the materials prepared appropriately for analysis. Responsibility and communication are key. So blood cultures are important as they support rational choice of targeted antibiotic treatment, and this can save a patient's life. It can also inform infection prevention and control measures. So what do we consider for blood cultures? You have to consider who, when, how, and where. Who should be sampled for blood cultures? Suspected sepsis patients or patients with suspected bloodstream infection should be sampled for blood cultures. And when we are talking about sampling suspected sepsis patients for blood cultures, so there are several issues with sepsis diagnosis in low to middle income countries, including Nigeria. Many patients receive antibiotics or other medication before presenting at the healthcare facilities. Patients often present later to the hospital due to out-of-pocket payments. There are high rates of children presenting due to demographics and the fact that they also come down with other infections. There is also high rising rates of immunosuppressive illnesses, chronic illnesses such as diabetes. So having multiple methods for diagnosing or having multiple data points to look at to diagnose a sepsis patient is very, very critical. One of the key data points that will help with sepsis diagnosis are vital sign measurements. There are several scores that have been validated to support rapid identification of patients with a suspected infection. One of these is the Quick Sequential Organ Failure Assessment Score, otherwise known as the Q-SOFA score. The Q-SOFA score is a bedside evaluation that may identify patients with suspected infections, but is more useful within the intensive care unit. It uses 3 criteria, 1 point each. The first is low blood pressure, that is systolic blood pressure less than or equal to 100 millimeter of mercury, high respiratory rate greater or equals to 22 breaths per minute, and altered mentation, that is a Glasgow Coma scale less than 15. And the score ranges from 0 to 3. 2 or more Q-SOFA points near the onset of infection is associated with a greater risk of death or prolonged intensive care unit stay. Another score is what we call the Systemic Inflammatory Response Syndrome. For adults, having 2 or more of the SIRS criteria is an indication of an infection. So heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, having a leukocyte count greater than 12, or having immature neutrophils band formed, and the core temperature greater than 38.3 degrees Celsius or lesser than 36 degrees Celsius is also an indication. Having any of this, 2 or more of this, is an indication of infection. For children, the scoring depends on the age group of the child. Umbelet et al. Also suggested criteria for sepsis case finding, which includes fever or hypothermia and one of the following signs of severity: either hypotension, confusion, increased respiratory rate, or suspicion of severe localized infection. However, in our communities and in hospitals in country, vital signs are still not being measured, or when they are measured, documentation remains poor. In the 2 hospitals where an evaluation for diagnostic stewardship took place, we can see that a lot of the vital signs were not documented. And when we come to blood culture requests, out of the 2,924 patients that presented, 82.7% had the blood culture requested, 1.9% had the blood culture conducted, with 0.4% becoming positive for an organism. This shows that blood cultures are still poorly or underutilized in our community. When we are also collecting blood cultures, as I mentioned earlier, you collect from suspected sepsis or bloodstream infections. When they should be collected, ideally prior to antibiotics, prior to when antibiotics are commenced, and once a patient presents, a blood culture should be collected. Where do you collect blood cultures from? You collect blood cultures from veins. Do not draw blood cultures from existing catheters of central venous lines, except when this catheter is newly established or if you are suspecting a catheter infection. Then you have to sample centrally and peripherally. Now, how do you collect blood culture? We have to consider volume and technique. Volume is more important than frequency of sampling. It is recommended that for adults, 20 to 30 ml be collected per set, and you need at least 2 to 3 sets to reach greater than 95% sensitivity. For children, based on the weight of the child, the ideal volume of a blood culture is also listed. I mentioned earlier that for blood cultures, we have to consider which are suspected sepsis, bloodstream infections, when prior to commencing antibiotics ideally, and once a patient presents, the blood culture should be taken. Where? It should be taken from the veins. How? The volume and technique is important for the how. Volume is more important than frequency of sampling. For adults, 20 to 30 ml of blood should be collected per set, and you need at least 2 to 3 sets to reach greater than 95% sensitivity. For children, the weight of the patient determines the volume of the blood that will be collected as shown. Blood sampling should be aseptic. The tops of the blood culture bottles should be disinfected and hand hygiene performed. The vein for collection should be identified prior to venipuncture. Adequate disinfection of the venipuncture site is crucial to avoid contamination. Skin should be disinfected with spirit and povidone iodine or spirit and chlorhexidine swabs. This is very important. If the blood volume is adequate, the anaerobic bottle must be inoculated first. If the blood volume is insufficient, the aerobic bottle can be inoculated only, but with the adequate volume. The required amount of blood should be drawn and the needle discarded in puncture-resistant autoclavable container following collection. The sample should be transported to the lab within 2 to 4 hours of collection. Contamination of blood cultures are not trivial. Contaminants may be regarded as true bacterial growth, leading to inappropriate prescribing. A systematic review of contamination of blood cultures showed that up to 59% of patients received unnecessary treatment with parenteral vancomycin as a result of blood culture contamination. This resulted in increased pharmacy charges, increased total laboratory charges, and the attributable hospital length of stay also increased. So while handling and also transporting blood culture samples, there are key points to note. The sample container must be labeled properly. The minimum essential information that should be documented legibly on the container includes the patient's full name, age, sex, hospital number, sample collection time. Once the sample is collected, the blood culture should be transported promptly to the laboratory. If this is not possible, store at room temperature. Do not refrigerate and keep the sample out of direct sunlight. Thank you for watching.